Morning all, welcome to this webinar chatting through the Women's Health report and the information that is in this published report that was published back in June, and we're going to chat you through how we got to the report, what the report contains. We're going to show you a video and hopefully have a bit of a discussion and a kind of question and answer as well, and some reflection time for us all. So we've got about an hour, but we'll see where we go with that in terms of, but we'll make sure that you're off in time to go and grab a bite to eat or to go off to your next meeting. So in terms of housekeeping, please keep on mute if you're not speaking, and you can raise your hand or pop questions in the chat if you've got anything you'd like to ask. This session is being recorded, so if you wouldn't like your face or your voice to be on recording, please just ask questions in the chat, and if you've got anything kind of urgent, you can also just let us know through the chat, etc. Alex will be monitoring that. Shall we do some intros?
Yes, just before we dive into those, in terms of I'm just thinking housekeeping and IT.
Oh, good point. Yeah.
When you shared your screen, did you share with sound?
Really good point. No, I did not. I was just thinking that. So let me do that now.
So yeah, I'm just thinking instead of getting there and
very good point. And it not working.
I'd rather we
good point.
Sort that now. Perfect.
Something I learned along the way.
Yeah. So I'll let Ellie introduce herself.
Yep. So morning everyone, my name is Ellie Story. I am a Senior Public Health Commissioning Manager at Notts County Council, and I lead on sexual health, women's health and the building blocks of health. So things like employment and health, housing and health, food and nutrition, and spatial planning and health as well. And Alex, over to you.
I'm Alex McNeese. I'm an ST3 public health registrar, so that means I'm in year 3 of my training to become a public health consultant. I have been working on a lot of oral health, and I've had quite big involvement in the Women's Health Director of Public Health and Communities report as well. I only have 4 days left, so that's all you need to know about me, really.
Fair enough. Yeah, so we're getting this in before Alex leaves us on maternity leave and then goes and rotates into her next training place.
Exactly.
So we'll kick off shortly, and yeah, please, if we could keep questions to the end. Oh, I've got a frog in my throat. If we could keep questions to the end, or when we've got some pauses, that would be great, just to allow us to kind of flow through. But yeah, please do pop things in the chat whilst we're chatting through, and we'll come to them at the opportune moment. So fab. Right, yeah. Alex, over to you.
Perfect. So the Women's Health Director of Public Health and Communities report was a report that spans over the 2-year time frame, 2024 and 2025. I think they are looking for people to do the 2026 one, and they're also looking for ideas. So please do shout up if this sparks your interest and you'd like to do something along these lines. So next slide, please. So the reason we chose women's health was around the Women's Health Strategy for 2022 and just the historical context as well. So a lot of people will know, you know, there's lots of different books, lots of different speakers, lots of different evidence around how women's health is under-researched, underfunded. And so we wanted to have a look at whether that was having an impact on our population within Nottinghamshire. Initial findings showed that the Nottinghamshire healthy life expectancy for women has been below the national average since 2009, and it's showing a decreasing trend as well. So it's actually getting worse. You can see from this infographic here that Nottinghamshire females are living just under 60 years in what we call healthy life. And then they have 23.1 years of ill health, that although their life expectancy overall is longer, the time spent in ill health is quite significantly longer than Nottinghamshire males. And so we wanted to pose that question, why? And, there could be so many different answers to this, even after we've done this report. So yeah, and I think it was just, this isn't about comparing, men aren't important or anything like that. This was about shining a spotlight on our Nottinghamshire females, and how we can support the Nottinghamshire females. Obviously, we do along this line have found lots of information about Nottinghamshire males as well, which will be sort of passed forward. So next slide, please. So what we did was we created a women's health survey that ran between October and December 2024. So this was to seek views on women's health from the people of Nottinghamshire. And at the time was the highest responded to survey within Nottinghamshire. Which I think speaks volumes. The fact that we had just under 1,000 responses to what I have to say was a fairly lengthy survey. We had, fairly good representation from across the population as well. And that led for some really, really great analysis of all of this data to ensure that we were sort of reaching our seldom heard populations. We did some interviews as well. So we reached out to people from a variety of different, seldom heard groups, and did semi-structured interviews. So we did 9 interviews in total, with 10 participants. So one of them had 2 people in. And again, got some really, really useful information and feedback around how we can best think about Nottinghamshire females holistically. We then did some really detailed data analysis as well. So you'll see some of the feedback from that data analysis as we move forward. But obviously, the data that we got was then complemented by national data sets and Nottinghamshire data sets as well. So not only did we ask the people and interview the people, but then we also used data from GP records, fingertips, those sorts of places that we were able to sort of get down to the crunchy numbers, really. And one of the limitations that we did find was that we weren't able to disaggregate some of this data by sex, gender, or geography. And so, when we're trying to look at things from a women's lens, that can be really tricky if we're if we're not able to look at this data from splitting it just by male and female, because it sort of just bunches everyone all together. Over to yourself, Ellie.
Thank you. And yeah, I would follow on from Alex's thing in terms of Alex's point around the data. It meant it was really difficult in terms of being able to draw some really clear conclusions. And you'll see later in the recommendations about where we were lacking data and where we would like to try and see some further work around this, because it was really a massive issue for us. When every hole we kind of turned down to try and every tunnel we tried to go down, we ended up down rabbit holes of where we didn't have the right information to help us answer the question, which was quite frustrating at times.
Yeah.
So in terms of women's health across the life course, we wanted to take a bit of a life course approach to understand what affect women at different points in their lives in Nottinghamshire. We also needed to compare that to men. So we looked at the main causes of reduced quality of life, and for women you'll see they're really quite different than men overall as a picture. So you'll see that musculoskeletal conditions and mental health disorders are similar for both women and men, but you'll see that other non-communicable diseases, and I'm sorry, it's quite small on your screen, but you can zoom in by using your plus minuses at the bottom of your screen. That third rung down on that top graph, you'll see is significantly larger in that pale pink than it is on the blue. And that will go into a bit more detail of why, but over 50% of that other communicable diseases are from gynecological disorders, which is the things that are causing women to live in many years with a disability. But you'll see that that isn't reflected, for example, in the years lost to early deaths. So you're seeing that those conditions are the ones that are causing people to live longer in ill health, but they're not necessarily contributing to mortality. When we look at the years lost to early deaths, you see that men are losing far more years to early deaths than to women, and that's reflected in their life expectancy that's shorter. But you'll see that we've seen for both men and women, we've got the highest rates of early deaths are coming from cancer and cardiovascular diseases, so CVD, and apart from neurological diseases, so things like dementia, women generally have fewer years of life lost to mortality. So what we're seeing with this is women are living longer, but they're spending a greater proportion of their lives in ill health compared to men. In terms of that other non-communicable diseases box that we saw on the third rung down, we needed to dig into that a bit deeper. And this data all comes from our an international study looking at the global burden of disease. And it's a little bit old. It's from 2021, and that data gets refreshed every 5 years. So we needed to look at this set. But I found this absolutely fascinating at just the sheer proportion of years lost to ill health for gynecological diseases within Nottinghamshire for women. And it counted in Nottinghamshire for nearly 5,000 years of life lost to disability. And that meant that for women in Nottinghamshire, there's greater loss of quality of life due to gynae issues than accidental injury, chronic chest disease, cardiovascular disease, or cancer. And that was absolutely instrumental in terms of changing some of our thinking about where what conditions may be causing this inequality in healthy life expectancy, and we then needed to align that and marry that up with what our women were telling us as well. So from what our women told us then, this actually married quite nicely with what the quantitative data told us in terms of the patterns of health conditions through people's lives, through women's lives. So we saw in our younger cohorts, we saw that mental health conditions were the highest condition that people had listed, most common condition in those aged under 50. And then around 50, we start to see things like menopause and perimenopause coming in. Anxiety and depression are still really, really high up there. And then as we see women age, we see things more like musculoskeletal conditions, and other conditions coming in around osteoarthritis, arthritis, back pain, knee pain, those sorts of things. And this married really nicely through a lot of the data that we saw in terms of thinking about what conditions affected women at different stages of their lives. You'll see throughout that things like endometriosis, which is a gynecological condition, come up repeatedly as well. So you'll see that kind of presence alongside those musculoskeletal and mental health conditions that we see as the top kind of causes on that previous graph. You'll see that those gynae issues are coming through continuously through what our women were telling us in our survey. In terms of what the survey kind of report overall told us, and we'll watch the video shortly, so this will tell you in more detail, but there were kind of some really core fundamental key findings through the combination of that qualitative insights from women and the quantitative data in terms of where some of the challenges were specifically for Nottinghamshire. So women described not being listened to by healthcare professionals, and this was something particularly women told us they felt fobbed off, and that came up time and time again when Alex was going through all of the data. We also that marries up with results from the National Women's Health Survey and the National Women's Health Strategy that women do not feel listened to by healthcare professionals. We also saw that a large proportion of people, 40% of people, reported barriers in accessing healthcare services, be that GP, be that pharmacy, be that hospital care, all those sorts of things. And the reasons for that were very complex and multiple. Women in Nottinghamshire are also frailer than men, so they're living in disability for longer and they have a higher rate of hospital admissions for falls and hip fractures, which also means that they're also overrepresented in our adult social care services, and that can mean that there's greater pressure on our health and social care services to respond to the needs of women being in ill health for longer as well. One of the things that was really shocking but sadly not surprising through this process was the sheer number of women who responded to our survey who had experienced domestic violence or abuse and or sexual violence or abuse. And that statistic is a national statistic in terms of 1 of 3 women will be a victim of domestic abuse in their lifetime. But we really saw that reflected through our local results as well, particularly through our interviews. That proportion was actually higher through our interviews as well. So it was very moving and also very humbling that women chose to share their experiences with us as well. In terms of thinking about some of those building blocks of health, and again, we'll go into this in a bit more detail later on, but these are the things that the building blocks of health are the things that influence more than 80% of our overall health and well-being. They've previously been called wider determinants or social determinants of health. So you may have heard them be talked about in different ways, but those are both building blocks where they're missing or they're weak, mean that people have less opportunity to thrive and to live long, happy, healthy lives. And we are losing years to ill health because of where these building blocks are weaker. And what we've seen for women in Nottinghamshire is that they've got lower levels of education, the national average. They've got higher levels of economic inactivity compared to men and compared to the national average. And the Women's Insights told us that they worry very strongly about financial instability, and that came through very, very strongly. And we know that money and resources and access to good work are absolutely fundamental core building blocks to support someone to live a long and happy, healthy life. We also saw very strongly that there were inequalities in terms of how women were accessing care and support for their needs. So we saw a real inequality in terms of the rates of hormone and replacement therapy prescription for the menopause and for long-acting reversible contraception prescribing, which are things like coils and implants to support, which can be used both for contraception but also to manage things like heavy bleeding or endometriosis or other gynecological conditions. What we saw was that certainly for HRT, there was a very strong correlation between the most affluent areas where the highest rates of prescription and the least economically affluent, so the most deprived areas had the lowest rates of HRT prescribing. We didn't see that exact correlation for our long-acting reversible contraception, but there certainly is a significant inequality in Nottinghamshire, where Rushcliffe PCN has by far and large the very much largest rate of LARC prescription, and everywhere else sits kind of hovering around the national average as well. There was also a lot around how many women report not feeling safe to exercise outdoors, and there being barriers in terms of their surroundings that prevent them from being able to develop those health behaviours that we would like in terms of eating well and moving more. And there are conversations ongoing in terms of some work that Notts Police are doing around the Walk in My Shoes campaign, in terms of how can we support women to feel safer to exercise outdoors, be that through lighting or creating those spaces where women can be supported to do so safely. Again, I won't go into these themes too much because we're about to watch the video, but just to give you a bit of an overarching intro, we managed to group all of the data and all of the themes into these 8 key themes, but what you'll see is all of them are very large overarching umbrellas of significant detail underneath them. We could have published thousands of pages of the information that we got. This was absolutely huge, and the information that we received. And so we were barely scratching the surface on this agenda. I think it's really, really important. So you'll see that they're very broad brush. They're very holistic in terms of those themes, because they had to be, given the sheer breadth of the information that we were gathering. So, as I mentioned, access to healthcare services are a big challenge, and women in particular was asking for spaces like women's health hubs or specific clinics or one-stop shops where they'd be able to be seen holistically, and they don't have to be passed between multiple professionals for their healthcare needs. Again, women wanted to be listened to, they wanted their voices to be heard, they wanted to be considering in the design of services that are specifically for them. We heard a lot about mental health and well-being, and also the burden of care and the impact that has, the caring role for women that has on women's mental health. We learned a lot about the proportion of women smoking and the proportion of women who are an unhealthy weight in Nottinghamshire, and we also have really high rates in Nottinghamshire in particular of smoking in pregnancy. So 1 in 10 women are still smoking in pregnancy, and that's very, very high in Nottinghamshire compared to other parts of the country. I really chatted through some of those building blocks of health, some of those core things that we see that women experience quite significant inequalities. And we already chatted through some of the violence against women and girls issues. But what I would say is we also saw very significant inequalities and barriers to accessing health and support for women who were from other marginalised groups. So homeless women, GRT communities, women from ethnic minority groups, the list goes on. But it was very, very stark in terms of what their outcomes would be. Women's health conditions in particular, we heard that women really didn't feel listened to when they were talking about specific women's health issues. So things like menopause, things like heavy periods, gynecological issues, those sorts of things. And that was really, really important for thinking about how can we start to change the narrative in those spaces? How can we start to make a difference for those women? And healthy aging, how can we support women to age well and to, whilst they're living longer, to spend a greater proportion of their life in good health compared to having multiple long-term conditions by the age of their kind of early 60s. So I'm going to try and play the video now through this. I hope it works. Let's see, and can you let me know if you can hear it?
Yeah, will do.
Oh. It's failing me. Right, backup plan. 1 second, bear with. So when we published the report, so the annual Director of Public Health report is a independent report of the Director of Public Health. So whilst we work for the council, it's not a specific council document or anything. And the previous Director of Public Health report had been so well received and had been done through a video format that we wanted to continue that and make it as accessible as possible to reach as many people as possible, to ensure that this video is well received and the information is received by as many professionals as possible across the system and residents as possible, because we wanted to make sure that the women who contributed their voices knew that their voices were heard and what we'd done with that information. So I'm just going to share my screen.
I've popped it on.
Oh, have you?
Yeah.
Thank you, Alex. You're a star. Fab. So
okay.
Let's go with that.
Let me know if you can hear it.
Yeah, we can.
Hello, I'm Vivian Robbins and I'm the Director of Public Health and Communities for Nottinghamshire County Council. This is my first annual report and I'm using this opportunity to shine a light on women's health and the inequalities that our female population are currently facing. Women in Nottinghamshire are living longer than men but spend more years in ill health. We've heard from many women across our county and I would like for you to hear their voices too. In Nottinghamshire, there are over 430,000 women, making up to 51% of our population. Our women have a higher rate of disability than the national average across all age groups. The The main causes for this are musculoskeletal conditions such as back pain, mental health disorders and gynecological conditions such as endometriosis.
The main issues that I've seen amongst women in my life have been things like PCOS and endometriosis, and I know that for a lot of the women that I've spoken to who've had these issues, they've taken a really long time to be able to even have that label and to get the help that they need.
I have met so many different people in the seniors club that we have coffees with here that have got similar issues to myself, either mental health or spine problems or arthritis problems.
Improving healthy behaviours for both women and men would have the greatest impact on early deaths. This includes reducing smoking and vaping, improving diet and increasing exercise. While progress has been made in reducing the number of people smoking in Nottinghamshire, reducing smoking during pregnancy remains a key area for improvement.
I would like women to have access to whatever they need to give them healthy years and for their lifespan to be at their maximum.
Access to contraception continues to be a key priority at a time and location convenient to women. Further work is required to support women to prevent unplanned pregnancies. Almost all women will experience menopause, where symptoms can severely impact on women's quality of life. Our research found this remains a taboo subject in Nottinghamshire, and there are inequalities in accessing treatment. We need better education on women's health conditions and understanding from employers.
So the menopause while working, wow, for me, it's been an absolute emotional roller coaster.
Women's voices are another crucial theme. Many women in our county feel their health concerns are not adequately heard or addressed. Our women describe feeling fobbed off and fighting to be heard.
So I don't really blame the healthcare professionals. They're trying to identify ways to tackle that issue, but at the same time I do think that I could have been treated with more empathy, and instead of perhaps being told that it was all in my head or it was just something that I would have had to deal with.
It is imperative that we listen to and validate women's experiences to provide comprehensive care.
It just seems like you just don't know that. You've had it done, we'll get you out the door.
We really need to take the time to listen to what the women in Nottinghamshire need and what it is they want to change.
Poor mental health was a prominent issue for women in Nottinghamshire. Anxiety and depression were the most common health conditions in women under 50 from our survey. We must prioritise mental health support and reduce the stigma associated with seeking help.
Then she referred it, she thought I needed long-term counselling, and I'm still waiting for the referral, and that's 5 years this August.
Access to healthcare services remains a significant challenge for many women. Our survey reported 43% of respondents experienced barriers in accessing services, such as delays when needing to see female clinicians. Marginalised groups including refugees, people seeking asylum, people who identify as LGBTQ+, and survivors of violence and abuse face additional barriers in accessing healthcare and support. They also experience poorer health outcomes than other women. It is essential that we address these inequalities.
I now generally choose to be seen by female clinicians because of my experiences of not being listened to.
There are several health conditions disproportionately impacting women later in life. Evidence suggests that women in Nottinghamshire are frailer than men and have a higher rate of hospital admissions for falls. We know many falls are preventable, and we are working together to address this across the health and care system.
Yeah, I think when you retire as a woman, you've worked all your life and you want to really enjoy your retirement, and it would be great to be fit and healthy to do that.
I've seen more of my friends navigate illnesses at an earlier age, seemingly more common.
The building blocks of health play a vital role in women's health. Lower educational levels, financial instability and community safety for women in Nottinghamshire are significant concerns, and we must work to improve these foundational aspects to support overall health and well-being.
I generally feel very safe in Nottinghamshire, but I don't feel safe walking on my own after dark generally.
I think that there's many things that contribute to people being in good health. From a non-health perspective in particular, having financial security, having good support systems, and being able to access and speak to the people that they need to when they do need help.
We recognise this work is just the beginning of our journey to supporting women's health. Through hearing these stories, we have developed recommendations to improve the health and well-being of our women in Nottinghamshire. Let me hand over to some women of Nottinghamshire to share these recommendations with you.
We and our partners have created a list of 10 recommendations to help improve the lives of women in Nottinghamshire. These recommendations are all of our responsibility to help drive change and reduce the number of years that women are living in ill health in our county.
Our first recommendation is to have a system-wide commitment to women's health from the Nottinghamshire Health and Wellbeing Board. This will ensure that we have a partnership approach to addressing the issues raised in this report.
Our next recommendation is to work with our place-based partnerships and communities to identify areas of the highest need so that we can work together in partnership to address inequalities.
Following our findings that so many women do not feel listened to, we want to ensure women are listened to more. Our recommendation is that we want to give women a voice and say in how their health is supported.
Women and girls' challenges with mental health has been one of the key findings of this report. We recommend working together with our partners to investigate what the barriers are for women to access support for their mental health and improve our signposting to offer support.
Our next recommendation is to continue to work with partners to reduce the rate of smoking in pregnancy in Nottinghamshire and to work across the system to help women and girls to feel safe to exercise outside.
We heard from many women about their experiences of health in the workplace. Through our work and health programmes, we need to work together with our partners to understand how we can further improve this and keep women in the workforce.
Our next recommendation is that we would like to ensure that healthcare services are trauma-informed and take an increased role in early identification and support for survivors of abuse and violence.
Our recommendation to support marginalised women is to develop a framework for women experiencing severe multiple disadvantage to identify areas of good practice for women and areas for improvement.
Our next recommendation is to build upon the existing commitment in Nottinghamshire to use the principle of making every contact count. We want to ensure that our healthcare professionals are provided with the appropriate training, skills and enabling environment to have conversations about women's health and to support women to access the right care when they need it.
Our final recommendation is designed to support women in Nottinghamshire to age well. We will do this by investigating early deaths associated with colorectal cancer in our county, understanding the impact of musculoskeletal conditions on women's frailty, and continuing to investigate the gaps in data around women's health that we have found during this project.
Together, we can create a healthier future for all women in Nottinghamshire. Thank you.
Thank you everyone for sitting through that. It was definitely a labour of love creating that, and yeah, we're very proud of it. So I'm just going to, Ellie, have you got the slides? Do you want to share?
Just resharing, getting that back up again. So I've popped the recommendations list in the chat because you've heard them in the video and it was really important that we wanted to think about them, but just having them to hand might be a bit more useful. And I've also popped in the chat the link to the website, which has both a longer written report on, but also the link to the video if you'd like to share that with any partners. So really, we thought we'd now move to the conversation part of this session, really, around where are the opportunities for you all to implement some of these recommendations in your areas of work? What questions do you have for us? Anything we can try and answer today? What work is already underway that we'd like to try and align with the recommendations? And where are the opportunities for women's voices to be heard through our networks, and how can we embed this? One thing I forgot to say as well before we do that is after the Health and Wellbeing Board, where this was discussed and published in June, we then held a workshop with lots of system partners, and we've been curating and working through an action plan over the summer months, which will be going back to Health and Wellbeing Board in December. So there's lots of things kind of underway in this space. That's why it's really helpful for us to try and capture some of that and see where that goes. So over to you all in terms of thinking about some of this in how you're working.
you want to come in, Kay?
Oh yeah, hi, hello. I don't mind starting off a little. Just
That'd
to
be
say
great.
that I work in the tobacco control and smoking area of public health, and at the minute we're working on a social media health promotion campaign that is about smoking in pregnancy, that is targeted at women of reproductive age, because it also includes some messaging about preconception. So I think that will work really well with the priority that you've mentioned in this report about smoking in pregnancy.
That's fantastic. Thank you for sharing and kicking us off. Kate?
Yeah, just wanted to add to that as well. Hi, I'm Kate, Public Health in the children's team in Nottinghamshire. And yeah, we're really interested as part of the LMNS, Local Maternity Neonatal System Equity Strategy, at looking at preconception health. So again, yeah, we're having, I know some of you have been invited to a meeting on the 30th of October, just to start looking at what the opportunities are there, really, and how we can pull some different work streams together around that. So yeah, I think that will link really well.
Amazing, thank you. And just to note as well, you might have noted that it wasn't sort of one of our key themes, and it wasn't something that we wanted to investigate sort of too heavily due to you know, things that are going on within maternity services at the moment. We have the Ockenden report ongoing within maternity services within Nottinghamshire. And so because that space is already being investigated, we A, didn't want to sort of tread on toes, and B, didn't want to give mixed messaging around any of that as well. So it's not that we haven't included it. I've been pregnant for most of writing this, so it's definitely you know, something that we thought about right at the start. So yeah, it'll be yeah, great to, it's great that this is still sparking conversations around sort of preconception and conception as well.
Yeah, brilliant.
Okay, any other reflections from anyone? Or questions about how we did it? How we did it, what was the most interesting, anything that shocked us or surprised us, those sorts of things.
Yeah, comments are fine too. And I think oh, Alice, you come in.
Hi there. That was really interesting, thank you. I just wondered, I don't know if you're opening up another time for questions, but I had something around the statistics on domestic abuse. I'm Alice, I work for a domestic abuse charity, Broxton Women's Project, and we're obviously aware of the national stats. However, I thought it was quite interesting that you said that the statistics were higher than the national average for the women who completed the survey. Have you got some sort of more definite figures on the statistics you got back?
So it wasn't for the women who completed the survey, it was for the women who completed the interviews. So by default, some of them were recruited because they were survivors of abuse. So it may or may not have skewed some of those results. So that's important for us to take. But we can absolutely go away and check through the data and see if there's any specific stuff that we can pull out. What I would say is it's such a rich data set, the information from the survey. So there's so much we could do with it. But we would be really happy to go away and have a quick look through and see if there's anything that we can pull through. I think some of this will also be potentially confounded by the fact that often domestic abuse can be something that people don't disclose in professional services and all those sorts of things, as you will be very well aware of us. And therefore the data sets are quite unreliable, and therefore in an anonymous survey people may feel safer to disclose that as well, or in an anonymous interview. So I think that was really interesting. One of the things I found so powerful about one of the interviews we did was a woman who said, I didn't think domestic abuse happened to women like me. And that was really, and she had lots of preconceived ideas about what it what it was, and she'd talked about and disclosed about her experience of going into hospital with various injuries at different points, and you know, trying to subtly say to people kind of what was happening, but not being listened to. And it was heartbreaking, honestly, that story, but it was really interesting in terms of thinking about where the opportunities are for us to do more. I mean, albeit this was, you know, her experience was 20 years ago plus, but it was really interesting. So we can absolutely do some digging. Sorry, it was a long way of saying we can do some digging
No,
and come back to you.
that's helpful, and it's also helpful for us to know these things when it comes to like applying for funding and things like that.
Absolutely.
Thank you very much. Thank you.
Yeah. I wonder, Ellie, if there is a way that we can actually share the initial questions that we asked as part of the survey. Obviously the qualitative interviews less so, because we had a sort of a rough structure, but it was very semi-structured, and we sort of just rolled with the women that we were talking to. But the actual survey itself was very planned. We have our outputs that are as part of the DPHC report on the website that Ellie has shared. There is the Women's Health Survey data analysis. There's a PDF that does include a lot of the sort of results from that. But if people wanted to see just the questions that were asked, I wonder whether there's a way I can extract that and potentially
we've got some Word versions that we'd done for printing, so we can send them around afterwards, I'm sure.
Yeah.
Kate, did you want to come in?
Yeah, it was just it's just a reflection, really. And it's right back to what you were saying at the start about data. And again, about, you know, looking at, for example, experiences of Black women, or, you know, people from different ethnicities. It's really missing, isn't it? In the data generally, because I know, again, you know, we're having lots of similar discussions again around maternity and around what data can be gathered and around what that shows us. And obviously there is a lot of data in maternity around Black women's experiences. So it's just a comment, really. Again, you said it right at the start in terms of some of the things that are more difficult to pull out. And again, I guess this is an opportunity, isn't it, with the strategy, to be able to dig into some of that a little bit more and see where some of those wider disparities are.
Absolutely. And, you know, I think one of the challenges of doing the survey and doing the interviews and all those sorts of things is you get a self-selection bias by those who complete it, and we were very mindful of that. And so whilst it was really well answered and really well received by women, there were pockets of our population that were definitely underrepresented compared to those who are out there and compared to our kind of census population. So we were very mindful of that, and that's why we wanted to do the interviews, to try and do some of that as well. And we did speak to 10 women through that process, but obviously resource capacity challenges, limitations, all of those things, to be able to have the time to find those women, to build up those relationships, to build the trusted scenario, to then do the interview, etc. All of that was fairly challenging within the really strict timelines that we had. So there are huge, I would say, there are not huge limitations, because it is pretty robust, but there are some limitations with some of the data, and we just need to acknowledge them, share them, accept them, and know that there are some clear conclusions that we can draw, but there's also loads that we can't, and there is much more work that we would need to do in those spaces, to hear the voices of more of those women who were missed out on this occasion.
And I think I was just going to say, that brings us really nicely to that third question around the opportunities for women's voices to be heard through your networks. And I think, you know, if anybody has got any sort of connections or, you know, things that they're doing just as standard, and about how we embed this into everyday practice as well. Perfect. Thanks, Laura. So Laura Armitage from Nottinghamshire CBS has said, I realise this is for Nottinghamshire rather than the city. I think that's a really interesting reflection, actually, because yes, it is Nottinghamshire. It is all sort of Nottinghamshire data. But you know, we have a population that is sort of transient across Nottinghamshire and Nottingham City. A lot of people that live in Nottinghamshire work in Nottingham City, and sort of access the city as well. So and access groups in the city. So so yeah, that would be great. So she said that I will use this information when talking to groups across the city, raising awareness and sharing links so they can use this within their work. I will also link this into work of NCVS through the practice development unit who work with those experiencing serious and multiple disadvantage. We have already started pulling in conversations around the building blocks of health through some of our work too. It's a really interesting piece of work, and the findings resonate through on the ground conversations we have with groups and women within our communities. So yeah, thanks, Laura. That's really helpful, and I think you know, anything that you can take from this and you know, pass forward is gratefully received.
Absolutely. And you know, I think it'd be really interesting at some point to maybe try and capture some of these ripples of where things have been happening, because we've been on a bit of a roadshow presenting this around the system, and from it, you know, I've had some really interesting conversations with GPs about things they could do differently with all these different partners, and it's resonated very strongly with women. I think generally no surprises from those women around that I've presented it to, but I think just seeing it there in black and white can be quite meaningful and moving. And one of my biggest learnings and reflections I would share with all of you is giving people the space to share their own stories if you're having these discussions, because whatever space I've been in, be that with counsellors, with members, with GPs, with fellow colleagues, with members of the public, people have wanted to share their stories, and they've wanted to share their experiences, be that for themselves, be that for some of our male counsellors have shared very deeply personal stories about experiences they've had with their partners or sisters or mothers, or you know, the women in their lives. And it's been really moving and humbling. And I think that would be a major reflection for me through this process, is just giving people the space and the time to do that, to share. Because I mean, as you heard, I was in the video, I have my own experiences of being a woman and having my woman's health. But yeah, we've all got it. And all of us have experienced challenges, or even if we've not, that's a great thing to talk about as well. So I think that would be a major reflection for me. I'm sorry for the rambling, but yeah, just feels like an important thing to note, really.
I think yeah, just on the back of that, any place that this has been shared, it's you can't put a 15-minute slot in. It just doesn't work, is what we found. It's too much of a poignant topic that people are really keen to get on the back of. So yeah, definitely emotive. Have anybody got any other either reflections, questions, or feel like they want to answer any of the questions that we've posed?
Fabulous. Well, I hope you all have a lovely rest of your day. Thank you for joining us today. Really appreciate it. This will be recorded and available through a link, so please do share it with other colleagues, friends, family across the system. And please, if you've got any questions, I've put my email in the chat, so happy to answer them. If you have a light bulb moment at 3 a.m, I won't reply at 3 a.m, but if you have a light bulb moment and you want to ask a question, please do let me know.